Okay, now we're going to have about a 15-minute panel discussion to get us back on time and get us to lunch. So, Dr. Goby has to go fairly quickly because she has to get over to St. Paul's for medical reasons. So if you have any questions for her, and that was about air pollution and why should it be a concern, I'd have you ask Dr. Goby now. Any questions?
Yes, Dr. G. I'm just wondering about the variation in the air quality in the Lower Mainland. For example, if I'm wanting to go for a walking exercise, should I choose going to the George Rifle Bird Sanctuary and walk out there, or should I go to the Pit Polder? You know, especially maybe it varies time of day with commuting volumes, you know,
Where
traffic.
is the Pit Polder?
You know, say Port Coquitlam, that area, Maple Ridge, you know, that area. You know, I like these natural areas, but maybe the air quality would discourage me from going to one versus the other.
Good question. So on some of the applications, you can look at the air quality because there's different monitors that you can like click on in different regions. So there's a lot spread throughout the Lower Mainland. So you can actually look real time at what the air quality measurements are in different regions and use that to guide you. There is a lot of variation within urban areas. So if you're exercising right beside a major highway or road, your pollution exposure is going to be higher in that setting than if you're exercising in a park where there's a lot of tree cover, which actually does do quite a bit to blunt the pollution exposure. So the farther that you are from major roadways, the more you're going to be kind of protected from that. So very much having these public green spaces, I think, is really important, and it can provide safer areas to exercise and do your activities. You want to add?
Just something to add, if you want to check out what the app looks like, I use the Air Visual, and I think Dr. Goby mentioned it in the talk that they have like a forecast, so they try to predict the air quality at different times, and I actually use that for my exercising, especially during wildfire season, so I recommend that, and I know you mentioned it, so you can take a look if you'd like.
Yeah.
Any other questions? There's various devices you can get to along with apps on your phone. I had what was called an Atmo tube. It was just a little wee device that I carried, and I connected up to my phone. So if I was out in trail someplace and it was smoky, it would tell me exactly what it was where I'm standing. Ron, you got a question?
Okay. Dr. G, have you done any studies on, in particular, on firefighters, urban firefighters, and smoke, take it in and contaminants through their skin, clothing, and as like people my age who didn't use air packs when we started, has there been studies done on that?
Yeah, that's a great question. There was one recent publication from the University of Chicago group that just came out, I think, either this year or last year, that did demonstrate that people in the firefighting profession do have a higher lifetime risk of developing interstitial lung disease. And we do know that other kind of inhaled occupational exposures are a risk factor for ILD development. We have not done that study in Canada yet, but certainly I think that it is something that is worth spending some more resources and time evaluating.
I have read the one from Chicago.
Yes, yeah, good study.
I just want to say is why the problem with the studies is that they don't want, Canada doesn't want studies from the US. They want studies from Canada. Ron's been denied WCB 3 times because we have no studies in Canada. And we've given them all those reports that we've gotten from other places in the world, and that one on Chicago is amazing, the one from 9/11. They're
Yeah.
not the least bit interested in those studies, which is very unfortunate because that's all we have to go
Yeah.
by,
Yeah.
other than his condition.
It's hard to conduct those studies when you're looking at a kind of registry cohort like we have in CarePF, where we're just enrolling people that come to care, because it doesn't fully reflect the entirety of the Canadian population. So when we're doing those studies to look at what's called like an incidence of the disease, there's a lot of statistical factors that can bias what we're demonstrating from that. So using a CarePF cohort to look at a disease incidence is very challenging. There's statistical voodoo that we can implement to look at it, but it is something that we're collecting more information about occupation as a part of our research, and hoping to incorporate a lot more understanding of that impact as we move forward. But I agree that it is an area that we are lacking in data right now.
Actually, I was going to ask you a question.
Sure.
If you have a deviated septum in your nose, will you get enough oxygen if you, like through your one nostril?
I guess it depends on a few factors. One is how deviated is the septum. So I've met some folks who have very severely deviated septum, and they actually can't breathe through their nose or their upper airway. And then, or if you're prone to a lot of nasal congestion, those are folks that'll have see the ENT specialists and see if anything can be done from that end. Otherwise, it's very challenging. You don't want to walk around with an oxygen full face mask, because it's not really easy to use, and that will further impair your quality of life when you're using something that's supposed to help with it. So usually I would have somebody see ear, nose, and throat and see whether or not there's anything that can be done about the deviated septum if it is that severe that we're not seeing that benefit with the oxygen.
Yeah, I find that sometimes it is not at all, and then other times it seems okay. But all of a sudden it became a concern. I thought, oh God.
Yeah, sometimes that can be treated even before thinking about things like more drastic, like surgery. It can be treated with medical therapy medications through the ear, nose, and throat specialist to help bring down congestion. But that can be a concern for a lot of folks.
Okay, I should go get that checked out.
Yeah,
Thank you.
definitely. Yeah, recommend it.
My question is a little bit broad spectrumed. The difference between using a concentrator as being on to the cylinders for oxygen, are they equal in regards to pulse rate? Like if I'm on 3 liters pulse on the cylinder, but on a concentrator, is it still 3 liters? Are you getting the equal amount?
So I don't know what the advertised answer is. I find that the tanks tend to give you more oxygen. They tend to be better. So we test people with oxygen tanks in the lab compared to the oxygen that they come in with their concentrator, and they seem to be getting more because their oxygen doesn't dip down so much. So I don't know what the sort of advertised answer is, but that's sort of in practice. Yeah, I do notice that the concentrators usually work for folks who have lower oxygen needs than for folks who have higher oxygen needs.
So on that same topic, during fire season, if you're using a concentrator, are you still being, or is it still as effective as being on the cylinders for smoke?
Yeah, it's still going to be effective. Like in terms of the amount of inspired oxygen that you get, usually a good rule of thumb is that for every liter increase in oxygen, so if you're on a flow rate of 1 or you're a flow rate of 2, it increases by about 3%. So you're increasing oxygen from 21% to 24% to 27% in terms of how much, and those fine particulate matter, there's such a small amount that can be really, really harmful, but they're not enough to actually kick off oxygen. Your oxygenation usually isn't as affected, but it's all of the other sort of irritation and the risk of getting that stuff into your bloodstream that's really problematic.
Are you saying that the oxygenator is grabbing the bad oxygen from the
No,
bad particles?
it's not taking in any of the negative particles. It's still just giving you the same oxygen. Those particles just happen to be bystanders in the environment that you're breathing in through the air that you're also breathing in next to the prongs, because you're breathing in pure oxygen from those nasal prongs, but you're also sucking in around the nasal prongs. You're breathing in whatever is in the air. So you're still breathing in, you're still going to be affected by anything in the air because it's not a closed system. It's an open system through the nose, and everything can get sort of past those nasal prongs.
Thank you. What are symptoms of pulmonary hypertension, and how is it diagnosed?
Pulmonary hypertension is it's challenging to distinguish from your symptoms of interstitial lung disease. I can answer the diagnosis question a little bit more easily. So it's highly suggested on an echocardiogram, a heart ultrasound. So usually if we suspect it, we'll send somebody for an echocardiogram, and that will give us a sense of how the right side of the heart is performing and pushing against those blood vessels. And we use that as a good indication. And oftentimes that's enough for us to say this person has pulmonary hypertension. Sometimes some folks we may consider even doing a catheter, so invasively testing the pressures in the heart by going through a blood vessel and running a little wire up into the heart to measure those pressures. But in most folks, an echocardiogram will be enough. The symptoms are very similar, so both will cause shortness of breath. You may have some chest pressure with both. Your oxygen levels drop in a very similar pattern to interstitial lung disease. We may start to wonder if somebody's oxygen levels are dropping much more quickly than we anticipate. Or if we look at your CT scan and we say, well, the CT scan looks like it hasn't changed very much, but the oxygen levels are dropping. Those are things that may cue us in. We should actually look for this. And then the physical exam and listening to the heart can sometimes reveal certain heart sounds that suggest that the heart is trying to fight against these tight blood vessels in the lungs. So those are a few ways that we can sort that out. But you as a patient, very hard to tell the difference between interstitial lung disease. It's just if your disease is getting worse, it's something we should think about.
Thank you.
You're welcome.
I have a question for Dr. Schaefer. The Snactivity, is that an app you can get on the App Store? Or is that
Yeah, so right now they're actually, I think, still looking at one of the apps in a research study, so there's nothing formally available yet. But I think a lot of the fitness and physical activity monitoring apps, you are able to sort of capture those little bursts of activity. So I think there's nothing formally, like there will be I think eventually a Snactivity app, but right now I don't think it's currently available. Yeah. Just to follow up on that, I got a lot of really good questions after the talk this morning, and a lot of people were asking about where they can find resources in the community for getting personalized exercise prescription, or maybe they're not eligible for pulmonary rehab or can't get in yet. How do they access supervised exercise training? And just 2 points on that. I think your care team can probably point in the direction of the provincially available resources. There are two community resources I'm aware of. So for in-person training by clinical exercise specialists who are aware of the limitations you might have and some of the adaptations you may need, so using supplemental oxygen, there's a private gym called LiveWell, and unfortunately it is a little bit expensive, but they do offer programs. I think it's about $37 a session, but they are for individuals who may require some special adaptations, and those individuals are really aware of your needs. We also have somebody named Jenna here from Popular Wellness, and I think she'll introduce herself. She's in the back having a conversation, but she provides personalized exercise training programs and some other services, but if there's something you want to do at home and you're looking for somebody to help you set a plan, her and her team seem very capable of doing that. So it'd be worth having a conversation with her if that's something that you're interested in, finding like a structured plan for you to follow that's tailored to your needs and your goals that you may have. So that's an excellent resource for sort of virtual or on your own training.
Yes, we have time for maybe one or two more questions, and that'll be it.
Hi, I have a question about the O2. So I recently, it has been explained to me that the O2, as far as the Health Canada is concerned, O2 is a drug as you mentioned it, but Health Canada is classifying it as a device, as a medical device, and that is causing problems on the reimbursement side of things, how it is available and things like this. So any ideas around that and how to navigate that from a policy perspective?
Ooh, that's a big question. Health Canada is very challenging, and they are incredibly rigorous, and even more rigorous than other countries when it comes to how they process devices. But it's challenging because it is a medication. The gas is a medication, but it's delivered within a device. And so those devices have to go through very strict regulatory approval. I wouldn't, and you know, in fairness, the medication that comes in that device is quite dangerous. So the way that that device can deliver the medication has to go through a lot of potential checks and balances, and they really look through, you know, every last little detail, including like the cord that comes out of the machine and how that plugs into the wall. And I don't have a great solution to that, because I wouldn't say that we should deregulate that, because I think it's there for a reason, and there's good sort of reason to have those safety checks. It can be a real problem for anybody who works in research. Anytime you want to try and approve a clinical trial, and other countries are doing these clinical trials without a problem, yet you're stuck at Health Canada waiting for an approval of whatever device, whether it's oxygen or some medication that's delivered through a device, and you're waiting for Health Canada approval, which just slows everything down in terms of research and development and getting treatment out to patients. So it can be a huge issue.
Yeah, and just like something to add to that from the policy side, it does take a lot of time, but we're actually specifically looking at hopefully changing some of the criteria for people being eligible for supplemental oxygen in BC. We have a large clinical trial across Canada. We're almost at 80 people right now, but hopefully soon we'll be able to at least provide some data that show that people who currently don't qualify for oxygen at all may actually benefit from oxygen for their exercise training, for example. But yeah, it just unfortunately takes time, but we're working on generating data to support some increased access, hopefully, but it might take a lot of time.
Okay, one more question here, and then we're going to break for lunch.
The pulmonary rehab course that you talk about, is that just for COPD and asthma? Because that's what it was for when I took it.
Yeah, they actually have pulmonary rehab open to people with interstitial lung disease as well. So I don't think it's specifically regulated for just those two diseases. So a lot of people with interstitial lung disease really benefit from that, and they are eligible for those programs. So I think you have to talk to your care team about what the eligibility criteria and the pathway is, the waiting time for where you live and where you're being seen.
Right, because I did learn a bit from it, but the majority of it didn't apply to me at all.
Yeah, so that's sort of what I touched on is, unfortunately, what the physios and RTs have to work off of is research in COPD, just by nature of them being a larger disease with more funding. So a lot of the strategies I've seen, so there's one paper that I read from 2018 from Australia. They're doing a lot of really interesting work there. A lot of the exercise training is just based on the American College of Sports Medicine guideline for healthy older adults. That's what it's called. And so we are working on trying to generate ILD population-specific training modalities, but it's taking time, but we're really trying. So yeah, it is. While people with ILD are indeed eligible, the strategies they're teaching you are based off of other individuals, and that sucks. There's no better way to say that, but it's unfortunate. But I promise that we are really trying to work on that.
If anybody's tuned in to CPFF,
from time to time, there's a posting on there that they can do virtually, and it's designated especially for pulmonary fibrosis. So that, other than being in a center, VGH, or in the lower mainland, we have the specific ones at some of the hospitals, but I do know that CPFF has posted, and they've got different places where you can look at it, that you can go and be part of that whole program.
Okay, everybody, I want to thank Dr. Schaefer, Gobi, and Minuk for their presentations and their valuable time here talking to us today. So thank you very much. Lunchtime.